My name is Colton Hill. I'm a second-year medical student at the University of Oklahoma. I'm also the Interdisciplinary Education Chair for the College of Medicine Executive Student Council. The Office of Interdisciplinary Programs is housed in the Office of the Vice Provost for Academic Affairs and Faculty Development on the OU Health Sciences campus. The office is charged with the development, implementation, operation, and evaluation of campus-wide interdisciplinary interprofessional education requirements. Today, we'll refer to this as IPE. That's the acronym for interprofessional education. We'll begin shortly, but first, a few housekeeping items. There's an attendance link that you should have received either in the comments section or as a poll. Please take a moment to sign in. We have guests from quite a few backgrounds, and we're excited to see kind of where everyone's coming from. Today's presentation is being recorded. Please remember to mute your microphones and use the chat function for any questions that may come up throughout the presentation. You can log your questions as a chat, and then we will revisit those in our Q&A section at the end. Sarah Cable and I will be your Zoom facilitators for this presentation. Please message Sarah directly with any technical issues. And without any further ado, I think that we'll go ahead and begin today's presentation on dyslexia. These are our learning objectives. This can kind of guide your thinking. We're going to post a post-presentation survey to kind of evaluate how well we discussed and explained dyslexia today. The first is to identify signs of dyslexia, and then to become aware of some common misconceptions that are out there concerning dyslexia, the treatment options that are available, and the testing or screening as well. And then also in more of a general sense that to recognize kind of the importance of the interdisciplinary nature of treating dyslexia. And with that, I'd like to introduce our team. We have a diverse panel of specialists today, provide a holistic understanding, hopefully, of the interdisciplinary nature of addressing dyslexia. It's my honor to introduce these speakers. Our first will be Sydney Kaiser. Sydney is an early childhood education teacher and reading specialist at Union Public Schools in Tulsa. She received her bachelor's degree from the Northeastern State University. She's taught first and second grade, but for the past year, she has worked part-time as a reading tutor, and this has allowed her to spend some more time with her new son. And she will return to Union Public Schools next year as a full-time reading specialist. So we're glad to have the perspective of the education system here today. And then next we'll have Dr. Nicole Andrews, who will explain the role of neuropsychology, testing, and diagnosis of dyslexia. Dr. Andrews is a clinical assistant professor and psychologist at the OU Child Study Center in Oklahoma City. She received her PhD from Oklahoma State University and completed her neuropsychology fellowship at the Hospital for Sick Children in Toronto. Dr. Andrews focuses on neuropsychological evaluations across childhood and adolescence, and primarily among children with medical complexities. She also directs the Neurodevelopmental Early Screening Team, also known as NEST. Following this, we'll have our reps from Pediatrics join us. Dr. Amy Bax from Developmental and Behavioral Pediatrics is here. Dr. Bax is an associate professor of pediatrics and the section chief of developmental and behavioral pediatrics at the OU Health Sciences Center. She received her MD and a master's in clinical and translational science from the University of Oklahoma. She serves as the medical director of the OU Child Study Center and director of the Child Study Center's Jumpstart Autism and Developmental Delay Evaluation Clinic. She also directs the OU Developmental and Behavioral Pediatric Fellowship Program, and she co-directs the Oklahoma Leadership Education and Neurodevelopmental Disabilities Program. She's conducted research specific to pediatric residents' parenting advice, preschool ADHD, and neurobiological differences in children with autism and ADHD. With Dr. Bax today is Dr. Rami Shelkoff. She will also be presenting from Developmental and Behavioral Pediatrics. Dr. Shelkoff is a third-year pediatric resident at OU Tulsa, and she will graduate residency this coming June and then plans to complete a fellowship in Developmental and Behavioral Pediatrics at the Child Study Center in Oklahoma City. After pediatrics, we will hear from Dr. Tammy Yanovich, who will speak on behalf of pediatric ophthalmology. Dr. Yanovich is a clinical associate professor of ophthalmology in the Division of Pediatric Ophthalmology at Dean McGee Eye Institute. She also serves as the Director of Medical Student Education at Dean McGee, And in her practice, she sees pediatric patients with a wide range of ophthalmic conditions and adults with strabismus. She earned her medical degree and completed her ophthalmology residency here at OU and completed her pediatric ophthalmology and strabismus fellowship at Duke University, where she also completed a Master of Health Sciences degree with an emphasis in genomics. She is the Vice President of the American Association of Pediatric Ophthalmology and Strabismus Learning Disabilities Committee and has been a panelist on numerous workshops about dyslexia. She serves as an associate editor for the Journal of Pediatric Ophthalmology and Strabismus and is an examiner for the American Board of Ophthalmology. And she is delighted to be on the panel and looks forward to improving awareness about dyslexia in Oklahoma. And after ophthalmology, we'll hear from a speech and language pathologist, specialists including Dr. Denise Finneran. Dr. Finneran is an assistant professor in the Department of Communication Sciences and Disorders in the OU College of Allied Health in Oklahoma City. She is the director of the Child Language Learning Lab, also known as CHILL, and specializes in language development and disorders in early childhood. Her research is focused on development in the preschool and early school years with an emphasis on grammar and dialect use. She is also a certified speech language pathologist who has worked with children and adults in a variety of clinical settings as well. With Dr. Finneran are Piper Allred and Anna Roki, and they are graduate students in the speech language pathology program in the Department of Communication Sciences here at the OU Health Sciences Center. And they are also research assistants in Dr. Finneran's lab. So we look forward to hearing from their perspective as well. And then last, but certainly not least, we have Dr. Christina Miller. She will speak to the importance of social work and family engagement in the approach to dyslexia. It's a very important topic. And Dr. Christina Miller is an associate director of the Anne and Henry Zaro School of Social Work from the OU Norman campus. She earned her PhD from Florida State University and has been at the University of Oklahoma since 2009. Her research is focused on improving post-school outcomes for youth with disabilities, school social work, and community-based participatory research methods. She has many research partnerships, both at the OU College of Education in Norman and at the OU Health Sciences Center, and serves as core faculty for the Leadership Education and Neurodevelopmental and Related Disabilities program. So we have a wealth of expertise here today, and I'm excited to hear it and learn as well alongside you. And with that, we'll kind of get right into it. So first, we wanted to have a sort of a fact or myth section. So I'd like just the audience to think about these statements and just think to yourself whether this is a fact or a myth. You don't have to necessarily post an answer in the comment section. This will be just kind of to prime your minds for what we discussed today. So the first is dyslexia is a rare condition. And I'll give you just a few seconds to think about that one. This is a myth. Dyslexia is the most common learning disability out there. It affects up to 1 in 5 children. And so it's definitely something that is deserving of our attention as educators and as healthcare providers. This one is dyslexia is caused by the eyes. It is a vision problem. Fact or myth? This is indeed a myth. As we'll learn further, dyslexia is not caused by a problem in vision. It is a problem with language processing. And so it is not a primary vision disorder originating in the eyes. The next is children with dyslexia see letters and words normally. Fact or myth? This is actually a fact. So one of the most common misconceptions is that children with dyslexia see letters and words backwards, or they reverse the letters. This is not actually the case. The primary sign of dyslexia is actually spelling problems. This is perhaps the most common misconception out there. As we learned just a second ago, it is not a vision problem. So seeing the letters and words is not the issue. It is a processing issue, which we will talk about further. And the next one is dyslexia cannot be diagnosed until 3rd grade or later. This is a myth. Deficits that are indicative of a dyslexia can be seen as early as 3 years old. These include deficits in phonemic awareness, rapid naming, and verbal working memory and letter knowledge. And these are identifiable precursors, as I said, in children as early as 3 years old. And actually, beginning in kindergarten, students should undergo frequent screenings, reading screenings, and those who demonstrate below average skills on screening should be placed into reading programs, and their reading progress should be monitored. Brings us to this one. It's dyslexia is often a developmental lag that the child can ultimately outgrow. This is also a myth. Dyslexia is a lifelong issue, and unfortunately, many parents hold off on testing or screening because they believe this is a phase that their child is going through and that they will kind of grow out of it. And this is not ideal, because we know that like 75 to 90% of children who will learn to read at grade level if they start their training as early as kindergarten or first grade, so before first grade. It is not a temporary learning phase. And with that kind of introduces some of the common misconceptions about dyslexia. I think we all have a general idea in our mind when we hear the term dyslexia, but it's kind of interesting to realize that it's very misunderstood. And so we'll just provide a little overview before we start here and kind of dive in of what is dyslexia. This is a language-based learning disorder characterized by problems in decoding language. So this is word recognition and letter recognition, and then reading these words out loud in a fluent manner. Children will also have issues with spelling, as I mentioned before. And this often originates with difficulties in the phonology center, so the speech sound system of language. And notably, it is not, again, a primary vision problem. It does not originate in the eyes. And it's not based on the child's IQ. Children with dyslexia often fall within average to above average IQ levels. So that's important to note as well. So for this presentation, we're going to go through our list, the specialists that we have on our panel, and kind of provide a case example to kind of help us understand everything that goes into approach to dyslexia. So we're using the case study of Thomas. Thomas is a 6-year-old boy in the first grade, and he's having trouble reading. He struggles with letter sounds and decoding words. When his reading comprehension skills are good when he is able to decode the text, and his math skills are also grade appropriate. He was delivered as a full-term healthy baby boy, but later exhibited speech delay, and there is a family history of learning disabilities. He has 2 older brothers, and his parents are divorced, and he splits time between his mother and his father. So with that, I'm going to pass off to Sydney Kaiser with early childhood education. She will lay the groundwork kind of for how children are often first identified in the educational system.
Hi, everyone. So as Colton said, my name is Sydney Kaiser, and I am going to talk about how we would identify a student with a reading delay within the school system. So each district probably does something differently, but along the same lines. I work for Union Public Schools, and we follow a tiering system to classify the levels of support that we provide a student instructionally throughout the day. So as Colton explained, Thomas is a first grader who struggles with letter sounds and in turn decoding words, which essentially means being able to sound out words. This is a skill he probably should have learned and mastered in kindergarten. So knowing this, he is not going to be receiving the amount of support necessary to grow as a reader with the tier 1, which is the whole class grade level instruction. Knowing this, his teacher would strategically place him in a small group of 3 to 5 students working on similar skills as Thomas. During this time, they would spend some time working on letter sounds and decoding, and then also spend time applying those skills into reading texts. Now, after a couple of weeks, Thomas's teacher may notice that the other students are progressing, but Thomas is still struggling and still needing a lot of support with his letter sounds. When she notices this, then his teacher would put him into what we consider tier 2.5. And this is one-on-one time that Thomas's teacher will work with him for 8 weeks on one skill and one strategy. Whereas in the small group, they might be working on multiple skills and strategies. So during 2.5, Thomas's teacher will each week document the skill they're working on, and then every day write down the level of support that she provides for Thomas. This will go on for 8 weeks. And again, at the end of this 8 weeks, if Thomas is still not making growth with this one-on-one time with his teacher, she's going to submit her documentation to what we call a child study team. This team consists of a school psychologist, a counselor, an administrator, and a special ed teacher. They will review the data taken by the teacher, and then they're also going to make sure that Thomas has passed both his vision and hearing screening. So if all of these boxes have been checked, they will move him into the final tier, which is tier 3. And this is where another teacher in the building, we refer to them as a skill builder or tutor. They're going to work with Thomas every day for 30 minutes on a target skill assigned by the school psychologist. So during this time, since it's 30 minutes, they're going to be able to spend more time on this one skill and then also practice it in some text as well. Similar to the 2.5 tier, the skill builder will write down the skill that they're working on each week and then daily write down notes about how much support they're giving him. And then on top of that, every 5th day that he is seen, he will be progress monitored on that skill. And then that way there's a really great checkpoint to see if he's making the growth or not. Now, similar to the other tiers, if at this point, at the end of the 10 weeks, he is still not making adequate growth, maybe he's learned a few new letter sounds, but it's just still not enough to go back into the tier 2 support. An IEP would be drafted by a special ed teacher, and then an IEP team would get together to hold an IEP meeting. So the team would consist of the child study team, as well as typically the speech pathologist, the general ed teacher, and then of course, Thomas's parents. So that's our tiering system. And then to talk about how we would involve parents in this process. So the hope is that Thomas's parents would be involved every step of the way. They would be given activities and reading materials to work with him at home that would support what he's doing at school and then also at home. So like games or activities, books that he's able to read successfully at home, or even books that his parents can read to him at home. From my experience, I've noticed that most of the heavier questions on whether or not a parent, a parent suspects their child has a learning disability, those questions typically come out during conferences or IEP meetings. We are educators, we're not doctors. So we do not diagnose in a school. We can suspect reading delays, and we can give, the information that we have about, their delays in reading. But should a parent come to us suspecting a learning disability, we would always first suggest for them to go to their primary care doctor or their pediatrician to get a further diagnosis or next steps in that. We are there to meet the child where they're at in their reading and help them grow. And then anything beyond that point would be passed on to a doctor.
Thanks, Sydney. And next we'll hear from Dr. Andrews from Neuropsychology. She's often very involved in the diagnosis and testing of dyslexia. And I'd just like to make a quick note before Dr. Andrews begins. We're presenting in kind of a specific order today in terms of specialists, but I just wanted to point out that in practice, children can be seen kind of by any one of these specialists first. So it can become kind of a complex process of kind of working together to refer to the different specialists. And often a child is found at the education level, but like Sydney was saying, they can also present at the pediatric level or directly to neuropsychology as well. So I just wanted to point that out. It really is an interdisciplinary process of kind of getting the kids all the help that they need. So with that, I'll leave things to Dr. Andrews.
Hi, everyone. So I'll start with how we diagnose clinically, so what the criteria for diagnosis are, and then I'll work my way into what that looks like for my assessments, both for Thomas and for kids in general. So as Colton was mentioning, there's sort of a complex referral process between all these different specialties. Because I tend to work with medically complex kids, most of my referrals come from one of their specialists or from their developmental pediatrician, sometimes from primary care. What I particularly enjoy are when kids are already hooked up with speech language pathology and other specialties, because you just have a much richer picture of what's going on going into my assessment. So the things that we're looking for are kids should be having difficulties for at least 6 months despite targeted help. So ideally, they're already going through this tiering system. You know that they've gotten extra help at school. We want skills to be substantially below age expectations. So not a particular gap there, but just below what we would expect. So like Colton was saying earlier, early signs may be present in preschool, but we really need for difficulties to be present in school. Now, those difficulties may be more acute as people get older and expectations go up, but there should be signs of challenges in younger school years. And finally, learning difficulties should not be due to other conditions like intellectual disability, an uncorrected vision or hearing problem, a neurological diagnosis. This comes up a lot for me with kids who have epilepsy or a history of stroke, lack of instruction. This has come up more during COVID, economic or environmental disadvantage, or difficulty speaking or understanding the language. If we have kids where English as a second language has not been fully addressed, we should hold off on a learning disability diagnosis in English. So what's missing from these criteria? What reading challenges are called has changed over time. You might have noticed that those criteria that I just showed you had nothing to do with reading or math or anything else. They're a general set of criteria for learning disabilities overall. So a lot of times families have concerns about, does my child have dyslexia? Does my child have a reading disorder? What's the difference between the two? So dyslexia, like was already mentioned, is a phonological problem. Do kids with dyslexia have a reading disorder? Yes. Do all kids with a reading disorder have dyslexia? No. So sometimes I have kids who really struggle with fluency with reading, but it's due to low processing speed, not due to a decoding or phonological challenge. Similarly, sometimes I have kids who have reading comprehension challenges, again, separate from that phonological piece. Another thing that's missing in these criteria is a required IQ academic discrepancy. So in the initial Individuals with Disabilities Act in 1975, that discrepancy was part of the consideration for a disability. As of 2004, it was no longer required. It's been removed from our clinical diagnostic guidelines as well. Some states forbid you from using a discrepancy model, and some states don't. And so it kind of depends on where you are. I'm happy that we don't rely on a discrepancy model anymore because it really penalized kids with lower IQ. So we know that kids with lower IQ benefit from targeted reading instruction. We know that kids with lower IQ have learning disabilities just like any other child. And that discrepancy model basically made it really difficult for them to get a diagnosis. So I'm glad that we've moved away from that. Another thing that's missing, again, because these are general criteria, are diagnostic subtypes. So you might read about phonological dyslexia, which is challenges in matching letters to sounds and sounding out words, or surface dyslexia, where you can sound out words but not recognize familiar words by sight, which would make it quite challenging to learn all the many words in English that do not follow phonetic rules. So the neurobiology of dyslexia, there is often family experiences with dyslexia. Having a parent or sibling does increase risk. However, it's not completely genetic. So if you have an identical twin who has dyslexia, his or her sibling will have dyslexia only 60 to 70% of the time. So it's not terribly clean cut there. Girls are not as readily identified, with ratios from 2 to 1 to 5 to 1. However, if all students are tested, that difference seems to disappear. So people think that that's because girls tend to have fewer behavioral challenges in the classroom, and so tend to be referred on for further testing less frequently than boys. But certainly boys and girls both have dyslexia at the same rates. Children with dyslexia tend to have a reduction in neuroplasticity and less activation of areas of the brain that process language and reading. Something that I think is really interesting is that evidence-based phonics instruction, which I'll talk about later, has been shown to increase activation in those areas of the brain for kids with dyslexia. The most important thing to note here, though, is that dyslexia is a clinical diagnosis. You're not going to do blood testing or imaging or genetic testing to get a diagnosis here, but it is a basis for research. So what this clinical diagnosis looks like for me in my practice is I always do an IQ test. Now, like I said before, that isn't required anymore, but it's nice to have measures of verbal and nonverbal problem solving and to rule out intellectual disability if that might be a concern. Achievement varies widely over childhood, but for Thomas would include early reading skills, single word decoding, so reading just a list of individual words, not in sentences, pseudo word decoding, which kids always think is funny. You're reading nonsense words that make no sense at all, but they follow standard English phonetic rules. And then reading fluency, which includes rate and accuracy. While it's not scored, I think prosody is really interesting. Are kids, following punctuation marks? Are they reading dialogue like it's a different special thing? Are they, including emphasis and interest where you might expect? And then also comprehension and spelling. So for Thomas, he's quite young. And so his reading skills might not be at the level where he's ready to read sentences or paragraphs of text. So some of those measures might be left off, but we can still get a rich measure of early reading skills for a 6-year-old anyway. We also include measures of phonological processing. I know the speech language folks will talk about that later. Ruling out underlying language challenges is one of the most important things for me. I get a lot of kids where families are very concerned about reading, and it is actually an overall language issue. So ruling that out, I would say, is probably one of the most important facets of my assessments frequently. And then also emotions, behavior, and social skills. Anxiety can come up both as because of challenges with reading or producing challenges in reading in front of a class, behavior, attention and concentration. Do we need to be thinking about ADHD? And then also social skills. Sometimes, especially with older kids, people have concerns about reading, but it's actually reading comprehension, and it's because of some underlying social challenges. So it's really important to get an overall picture of how kids are doing.
Thank you, Dr. Andrews. Next, we'll hear from Dr. Amy Bax and Dr. Rami Shelkoff about the role of pediatrics when addressing dyslexia. Often children are first seen by pediatricians, and Dr. Bax will also discuss the role of developmental and behavioral pediatrics specifically.
All right, so I'm going to start. So like you said, now we're going to talk about dyslexia from the pediatrician standpoint. So we know that there are early literacy skill deficits and red flags that can be measured at a preschool age, like we've already heard. And these can be identified by a pediatrician even before kids enter school. Most kids are followed by a primary care provider, including a pediatrician from a very young age. And so it's important for pediatricians to remember that sometimes we are the only professional contact that a child may have before even going to school, if they're not in a daycare or preschool setting. So as pediatricians, it is our role to help guide families through these things. And then taking a step back even further, even before this age, and kind of bringing all this back to Thomas, it was important that Thomas had early broad developmental screenings. This can include the Ages and Stages questionnaire. This is the most commonly used evaluation in our clinic and several other clinics. There's also the Parents Evaluation of Developmental Status, which is known as the PEDS evaluation. This is also used in some clinics. And then, of course, the Modified Checklist for Autism in Toddlers, known as the MCHAT. These are just a few tools that can be helpful in identifying early delays that may place Thomas at risk for later dyslexia or other learning disorders, as well as helping to identify interventions that could help him. It would also be helpful for Thomas's pediatrician to ask or evaluate things such as how Thomas does with rhyming sounds, repeating nonsense words, or reporting the sound that a letter makes. These are some of the things that we've already heard about, but the pediatrician can help kind of pick up on these things. Thomas's pediatrician needs to keep a wide differential of things that could be going on in addition to potential dyslexia. As pediatricians, we often hear kind of a vague report of various challenges that the child is having, and it's our job to help think through things that it could be. And so some other things that are helpful to think about, and we've heard about several of these already, dysgraphia and other learning disorders, an underlying language disorder, intellectual disability, autism spectrum disorder. With autism, there can be reading challenges that aren't necessarily about the mechanics of the reading, but about the social and other communication aspects that go with it. ADHD, as pediatricians, it is common that we need to help determine if a child has ADHD, a learning disorder, or both. Depression, anxiety, these can definitely impact a child's performance in these areas. Other disruptive behaviors, such as oppositional defiant disorder, as well as hearing and vision disorders, and these should definitely be screened for by the pediatrician as well. Now I will turn it over to Dr. Bax.
Thank you. So a lot of this, there can be overlap between the pediatrician or family physician and a developmental behavioral pediatrician. We often get referrals in developmental behavioral pediatrics for these types of concerns that Dr. Shelkoff just mentioned, that differential diagnosis might be turned over to the developmental pediatrician to kind of help narrow in what may be going on. So whether it's a pediatrician, family physician, or developmental and behavioral pediatrician, we'd ask that a really strong family history of dyslexia or other learning or intellectual disorders be elicited. Just like Dr. Andrews was saying, there's a strong genetic component. And so this can be really key. It's often helpful. Families don't necessarily use those terms. So you might not want to say, does anyone have intellectual disability or a specified learning disorder in reading or dysgraphia? But did anyone struggle? Did anyone in your family struggle in school? Did anyone receive special education or extra learning or tutoring supports? That can be a more neutral way to elicit that information. And then really trying to recognize what interventions or assessments have already been done by the school. As Sydney was discussing earlier, you know, if there can be that communication between the schools and the parents, and then toward their medical provider, that can be very helpful. So encouraging parents to bring reports, progress reports, if there already are IEPs or 504 plans in place, that can be valuable information for the pediatrician or medical provider to review to help determine that risk for dyslexia or other learning disorders. As Dr. Shelkoff said, early intervention is key. So if we can really identify early developmental delays, language delays, motor delays, then we can start that intervention promptly, which we do have evidence that then results in better outcomes for the long run. So this would apply for dyslexia too. If we can really identify language disorders at that younger age and make sure children are getting as much intervention for that, that can be helpful. And if it didn't happen at the younger age, advocating that they may need language therapy even into the elementary school years. I think sometimes that can be challenging. A lot of us think, I know the next group will be talking about this, but a lot of us in medicine might think that speech language therapy is only about speech and articulation, but really we can encourage families to seek out that type of therapy to support the underlying language development, which will be helpful when kids are at risk for dyslexia. And we really, in pediatrics, we have Bright Futures, the American Academy of Pediatrics, IDEA. We have lots of folks out there, entities that are really advocating that we do try to identify this nice and early for the best outcomes. And this is just a picture representation of that. If we can start identifying those language disorders when kids are toddlers or preschoolers, you can see that it's a lot easier to kind of help with that block stacking versus if we haven't identified problems and the new problems keep building on top of that, it gets harder and harder to correct course. And so I think in our role in pediatrics or developmental pediatrics, we can recommend that families request a school-based assessment or IEP, or start with that conversation with the teacher. I think that can be crucial just to get some insight. If they aren't totally aware of what's going on with school, request a meeting, a phone call, or a formal assessment if you can determine that other steps have already taken place. And then what we can do outside the school setting, if that progress and plan is already in place, but we really do have concerns for dyslexia or learning disorders, we can place that referral to the neuropsychological for the neuropsychological or psychological evaluation to dive in and do some of the assessments, as Dr. Andrews was mentioning. This is really key. Dr. Andrews works with our team really closely. We're kind of spoiled to be basically one floor down, but it's really nice to keep that dialogue open, being able to review her reports or talk through challenging cases. So I encourage medical providers to maybe identify their psychologists or neuropsychologists in the community if they do have questions, and get comfortable with reviewing reports, asking families to share the reports after those evaluations have occurred, and getting comfortable likewise with reviewing school documentation. That's probably something most pediatricians and family physicians don't realize will be part of their role. And so then we wanted to touch a little bit on some practical considerations. So insurance coverage is a legitimate concern for the formal neuropsychological evaluations. If you only have documented what they would call pure educational concerns, their academic success, some insurers might deem that needs to be an assessment that occurs in the school setting only. So if you're not really careful to indicate other potentially complex factors that would explain why you need more than just that school assessment to determine educational interventions, insurance may deny coverage. So it's really helpful if there are additional concerns beyond the academic or learning disorders to go ahead and list those. Lots of these have been mentioned already, but like we said, if we're really not sure if we might have a formal learning disorder or intellectual disorder, if these might be in the context of other conditions you're aware of or not aware of, but wondering about, That's going to strengthen the reason for the neuropsych referrals. So these would again include wanting their assistance in ruling in or out autism, ADHD, emotional disorders, prenatal substance exposures can contribute to these challenges. Making sure hearing and vision have been screened at least, and then understanding whether they have a neurologic or genetic or other chronic health condition that would warrant this type of assessment. So we can do our part to really describe this child as a whole and why getting this evaluation is crucial.
Thank you, Dr. Bax. Now we're going to move on to ophthalmology, and Dr. Yanovich will talk about the role of ophthalmologists when concerning dyslexia and how a primary vision issue is ruled out, and kind of really elaborate on that.
Thank you, Colton. Hi, everyone. I'm a pediatric ophthalmologist, so I see patients like Thomas in my clinic every day. Most of the time, they're referred to me by their pediatrician to check their eyes and make sure that there is nothing going on with the visual system that could be causing the child to have an issue learning to read. And so my role is specifically to rule out any condition related to the eyes that could affect their reading. You might be wondering why I'm sharing this lovely 80s retro photograph with you. That's actually me. Back in 1980, I was 6 years old, and I, like Thomas, was having a difficulty learning to read. And at that time, both my parents and my teacher felt that I was bright enough to learn to read. And so they didn't really understand what was going on, but my parents did happen to be friends with a neuropsychologist who was able to assess me and actually ultimately diagnose me with dyslexia. And fortunately, I underwent kind of intense multi-sensory intervention, and there was a emphasis on learning phonics, which helped me immensely. And gradually, as I progressed through my education, my reading skills improved so much that I was able to successfully get accepted to medical school and complete my medical school training. And so I come at this problem with kind of two different lenses. One, as a pediatric ophthalmologist who is concerned and interested in the eyes and how the eyes can affect reading, but also as somebody who had dyslexia as well, or has dyslexia. I guess that's technically the right way to say it. So next slide. So we're going to go back to our patient Thomas, and when he's referred to the pediatric ophthalmology clinic, there are some specific visual components that we need to make sure are intact, so that we can be assured that his vision isn't a source for problems with his reading. And as we all know, vision is an essential component to reading. We need to be confident that he has visual acuity that's good enough to see the words. And in order to do that, he has to be able to focus his eyes, which is called accommodation. He also has to be able to pull his eyes in so that they can work together. And then he has to move his eyes across the page. And this is done with kind of quick, jumpy eye movements that are called saccades. And then his eyes have to stop and actually fixate so that they can gather information. So in the eye clinic, these are all things that we're going to be paying attention to and testing to make sure that they are working properly. So to check Thomas's visual acuity, he may not be familiar with all of his letters. And so we may have to use an alternate way of testing that. And there are several different types, or we call them optotypes, of things to test his visual acuity that we can use. One is Leah symbols, which is basically just 4 symbols: a house, a square, a circle, and a heart. And what you'll notice about those symbols is they're the same, even if they're flipped, it doesn't change what your response would be as far as what those symbols are. And then the other test that we can use is a test called HOTV, where we just use those 4 letters. It kind of simplifies the test. And again, those letters, if you flip them, are going to give you the same response. And we're going to want to check his visual acuity both at distance and at near. Functionally, near visual acuity is more important especially when you're trying to do a task like reading. And so we want to make sure that that is intact. And then another important part of his exam and checking his acuity is checking for an underlying need for glasses. And so we're going to do a test called a cycloplegic refraction. And what's important about this test is that the pupils need to be dilated with drops that will kind of relax his focusing muscles so that we can determine the full amount of error that his eyes have, because sometimes a child can have an underlying error that they're compensating for that is affecting their vision, and that might be undetected if they're not dilated. So a dilated exam to look at this is really critical. The other point that I'll bring up with that is that preschool, 1.5% of preschool age children in the United States have a form of visual impairment. And majority of those are basically just needing glasses. So this is really a critical thing for us to take a look at. And it's more common to have a vision impairment in children that are African American and Hispanic. So that's another element to just be aware of. For Thomas, the other components that I had already mentioned that we are going to want to check are accommodation and convergence. So accommodation is the ability to focus your eyes. And most kids have an amazing ability to focus their eyes. This is why a lot of times you'll see kids holding things right up into their face to see. It's because they have such great focusing ability. But there are some conditions that can cause problems with accommodation. Specifically, children with Down syndrome may have reduced accommodation. Also, there are some medications that can affect accommodative ability. And then head injury, kids with concussion may have issues with accommodation. So we want to be sure that the eyes are able to focus at near. And the tests that we do are accommodative amplitude and facility, dynamic retinoscopy, and near point of accommodation. And then once we can determine that the accommodation is intact, we'll also check convergence, which is your ability to pull your eyes in and have your eyes work together at the same time when you're focusing on a near target. So if you wanted to check your own convergence ability, just take a near target or something to look at and pull it in towards your face and try to get your eyes to cross. And that is an example of convergence. And so there are some children that don't have a very good ability to converge, and this can cause them to have eye strain or eye fatigue with prolonged reading. But I guess the important point to note about that is that if they do have an issue with convergence, it doesn't cause them trouble learning to read. It's more of a sustained act of reading where they're going to have trouble, the longer that they do that activity. So we wouldn't expect a problem with convergence to cause them necessarily a problem learning to read. So this is another point that I wanted to bring up, and that is that reading does not involve smooth pursuits. So smooth pursuit is just your eye's ability to move across the page, and that's tracking. And actually, a lot of kids will come in to the eye clinic because their parents think they have a tracking problem that is affecting their reading. And this video just illustrates what your eyes do when they track. But if we actually look at what the eyes do when we're reading, the movements are the saccades, which in the next slide will kind of illustrate what your eyes do during a saccade. The saccades are kind of a small, jumpy eye movement that's used during reading. And then your eyes pause, and this pause is called a fixation. So fixations make up about 90% of the reading time. And fixation time varies depending on the skill level of the reader. Most of the saccades in like a mature reader will be forward saccades, and occasionally they'll go back and recheck, but most of the time they're forward. In a new reader or somebody that is immature in their reading skills, they're going to do more backward saccades, and that is just a result of the fact that they're an immature reader, but it does not actually cause them to have reading issues or reading abilities. So training the saccade movements is not going to improve the reading of ability of somebody with dyslexia. So in summary, an eye exam is essential to make sure that there are no visual problems that could be interfering with reading. If there is a visual problem and we correct it, and there's no underlying issue with learning to read, then we would expect that the problem is going to improve rapidly. And if it doesn't, then you want to move on and suspect or check for something further as far as dyslexia goes or learning disability. And then, you know, from what we've heard so far and kind of what I've shown you, it's important to note that dyslexia is a language-based disorder, and it is not caused by problems with visual processing or eye movements. And the treatment for dyslexia requires a structured literacy approach with a emphasis on phonemic awareness, and vision therapy or training saccades or using special lenses are not going to fix that deficit. And so once I see the patient and I rule out any visual problems, I will send a report back to the pediatrician's office so they know what has happened in the eye clinic, and if there are any issues or problems, then we'll treat those. And then also I use the visit to educate the family as far as what should be happening with further testing, and encourage the family to pursue that testing and kind of support them through the whole process.
Thank you so much, Dr. Yanovich. We appreciate your expertise as well as you sharing your personal experience. I know it adds something to this my learning experience for sure. So thank you. Next, we have Dr. Finneran from Speech Pathology. Speech pathology is a very crucial piece of this puzzle, and they're certainly one of the disciplines that could see the child at any point in the child's management, whether it's the initial consult or at really any point along the way, both assessment and treatment. So with that, I'll leave it to Dr. Denise Finneran.
Thank you. And thank you for the wonderful lead up by everybody else who has come before. I am on this in this Zoom window with Anna and Piper. So we're going to work through our slides by turning off the camera. The next person will pop into the screen. We'll turn on the camera again and to keep the transition smooth. So if you see us disappear, we're coming back. So literacy is a language skill. And so to address literacy, we have to address language, as we have said before. Please forward the slide. So in an assessment, anytime we assess a child, we do a full assessment, regardless of what the diagnosis or suspected diagnosis would be. So for Thomas, we would look for significant family history and child history. And in this case, there is a history of learning disabilities. Thomas has a history of a speech delay, problems with learning letters and decoding words, but reading comprehension seems okay compared to peers. Thomas is receiving some tutoring in school, but is still struggling and is being considered for an IEP. So those are all red flags for sure. And so So what we would want to know is what other concerns would there be with health and communication, for example, hearing, chronic otitis media, chronic ear infections, and other communication concerns, and what are the child's strengths and weaknesses so we can get a full profile for that child. Okay, please forward. So for Thomas, we would do standardized testing, which standardized testing gives us those lovely standard scores that schools and insurance companies love to qualify a child for services. And we would do that for grammar skills, semantic skills, such as vocabulary, articulation, etc. Hopefully there would be time to do a natural speech and language sample, listening to the kid talk, recording them, looking at how they use language in natural conversation. And also screening for other problems. We will do an oral motor examination to see if there's any structure or function that might need a referral. We'd see if they've had a hearing test. We'd look to see if there might be concerns with, for example, stuttering or voice problems, etc. So this would be part of a full assessment. And please forward. And then because this child is coming in with concerns for dyslexia, regarding dyslexia, we would target the phonological skills more specifically. And there are full standardized tests, criterion reference tests that will do this. So we would have some phonological assessments ready. We would look at phonological skills, and what that means is Thomas's knowledge and use of the speech sound system for his language, which in this case is English. And so we would assess some different areas. So for example, the phonological awareness skills, which is the awareness of sound structures. So for example, what's the first sound in the word cat? For phonemes, which are individual sounds, or syllables in a word, say toothbrush. Now say toothbrush without saying tooth, or how many syllables are in toothbrush. And then also something called onset rhyme, which is the first consonant and then the rest of a syllable, like bold, now say bold without buh. And so these are some examples from an examination, a standardized test of phonological skills. Please forward. Some more things that would fall in this category would be something called phonological memory, which you can think of as short-term working memory for speech sound, spoken language, phonological information. So an example of that is I'm going to give you a list of numbers and you say them back just like I said them in the exact same order. And then also something that a test that in, for example, the CTOP is called phonological processing, but what it is how rapidly can you come up with the names and say the names of things accurately. So for example, letters, something that this child knows, but can they say them really fast, or colors or animals? And so these are all assessments of phonological abilities that would be specific to that question about dyslexia. Please forward. Okay, so now we are in the intervention phase. So I'm just going to turn off the camera quickly while we transition. And first we will have Anna talk about this first part. So give us just a second.
Hello. All right, so starting with Thomas's intervention, we would work on decoding through phonology and alphabet knowledge. So starting off on phonological processing skills, this is the knowledge about the sound system in a language or how speech sounds form words. So one way we can work on this is syllable awareness. So we would ask Thomas to clap out the syllables in words. Looking at our example word panda, panda has 2 syllables, so we would clap twice, panda. Another thing we can work on is phoneme awareness. This is identifying the sounds in words. So this would help Thomas understand how phonemes make up words and how changing a phoneme would change the word. So for our example, we would look at cat. We would ask, what is the first sound in cat? Now change that first sound C to an H. What word does that make? Hat. And matching those up and recognizing the difference of the phonemes. Another thing we would work on with Thomas is alphabet knowledge skills. So this is the sound to letter connection, or how speech sounds or phonemes connect to the alphabet letters or graphemes. One way we can work on this is using flashcards to teach identifying sight words and then grapheme combinations. For example, we can use these cards to help Thomas recognize words like bed or said, for example, and identifying these words by sight, and also identifying the grapheme combinations. So for example, the AI in said sounds like the E in bed, and recognizing that they are spelled differently but said the same. We could also use these flashcards to work on spelling patterns in the language and typical spelling rules. So looking at our cards, night, fight, sigh, and sight, we could use these cards to help Thomas recognize that the IGH makes the I sound. We could also use cards to recognize like TH, CH making sounds, and rules like ING in English, typically going at the end of words and not at the beginning. So while these activities may seem simple, they are foundational skills for reading and writing that Thomas will be using. They'll help him with the ability to learn, later developing language concepts, which Piper Allred will discuss.
Once Thomas is able to recognize sight words, we want to work on those words in the context of sentences. And working on words in the context of sentences is how we give words meaning. So by assigning meaning to a word, this allows a child to become more familiar with a word and recognize that word in various contexts over time. So for example, let's look at the word sight. So in the first sentence, the London Bridge is a famous sight. The word sight is defined as something that can be seen. And in the second sentence, he caught sight of his car, or he sighted his car, excuse me. The word sighted means the ability to see or observe. So we can see how in these two sentences, we have the same word, but they do have slightly varied meanings depending on how you use the word. And this allows the child to recognize the same word in a variety of contexts over time. So once we've worked on meaning, we want to take meaningful vocabulary and sight words and apply this to sentences. So one way we want to do this is we want to look at the roles of words in sentences. So kind of going back to our previous sentences, in the sentence, the London Bridge is a famous sight, the word sight functions as a noun. And in the second sentence, he cited his car, the word sight functions as a verb. We also want to teach where parts of speech tend to occur. So for example, articles generally occur at the beginning of sentences. Articles include words such as the or a. Nouns usually tend to occur at the beginning or at the end of a sentence. And verbs usually do not occur at the beginning of a sentence. And so teaching this allows Thomas to recognize patterns in language, which helps him to better be able to recognize words that might not be as familiar to him. In addition to that, we also want to teach markers on words. So this would be prefixes and suffixes. These change meaning or part of speech. So for example, the addition of ed in the word cited changes the word sight to cited. So that changes the word from present tense to past tense. And then another example of that would be the addition of ly. So changing the word from sight to sightly. That changes the word from a verb to an adverb. So why do we work on this? When Thomas has knowledge about a word, such as meaning, role in a sentence, etc., he is better able to use these tools to recognize the word in the context of a sentence or reading passage.
Okay, thank you. We really appreciate that insight into speech pathology. We're going to go back and hear from Sydney Kaiser again from the world of education. There's a bill that was recently passed that we would sort of be remiss if we didn't discuss, and she's going to talk a little bit about something that's been going on in the Oklahoma State Legislature, specifically concerning dyslexia.
Yeah, so to preface or to before we talk about the bill, full transparency, within a school system, unfortunately, dyslexia currently is not recognized as a learning disability on an IEP. And I know IEPs have been mentioned quite a bit, so I wanted to talk a little bit about specifically what an IEP is. It stands for an individualized education plan. And this is a legally binding document that spells out what services a child will receive. There will be annual goals. And so annually the IEP meeting will be held with the child study team that I mentioned earlier with the parents. And then it will also state the services provided as well as any accommodations in regards to testing and assessments that a child would receive. And then it would also specify what the reason for the IEP. Most of the time, they are under the category of specific learning disability. And this is kind of just a big umbrella of that could be meaning for reading, math, writing, spelling. It's just a big umbrella of different disabilities that a child may have. So at this, as I said before, at this time, dyslexia is not recognized on an IEP. There's also currently no mandatory training for teachers for dyslexia. And but moving forward, there has been a House bill that was passed, and that states that beginning in the next year, 2022-2023 school year, any students in grades kindergarten through 3rd grade that are on a Reading Sufficiency Act, which means that they are below their current grade level in reading, will be screened for dyslexia. This screening is not a diagnosis for dyslexia, but it's to kind of find those early indications or characteristics of dyslexia. And then they're also in the works within the districts of training for teachers on dyslexia. So I think that this is going to be a great thing for students, families, teachers, all across the board to learn more about dyslexia and learn how to better serve students who might show those early indicators of it. And then also, as previously talked by the pediatrician and other people, they all want information from the school. So this will be information that we can give to families to pass on to outside resources.
Okay, thank you, Sydney. We're going to go ahead and move on to our last subject, which is social work. So we're going to hear from Christina Miller about the vital role of family engagement and support and resources that are kind of addressed by social work. So I'll leave it to Christina Miller.
Hi, thank you. So social workers, we find ourselves in many different sorts of settings. So the way that we would interact with someone like Thomas and his family would vary based on the kind of workplace that we were representing. So if we're in a medical setting, we might be a part of the team that's working with Thomas's family to do that deep dive into their family history and finding out more information about them and helping to refer them to important community resources, helping to prepare them to take the information they get from the medical team and take it back to the school setting. If we're in a school setting, working as a school social worker, then we would be part of that IEP team that's having meetings with the family to discuss concerns that they see with the student or planning for their educational success within the school year. Also, a student may come to be screened for dyslexia because they're having trouble with reading, but maybe they're also seeing some problems with behavior in the classroom, etc., all due to the trouble with reading that may be causing them to act out. So that may be a reason that the teacher is reaching out to the school social worker as well. Hey, I need some help. This kid is acting out. Where can we go from there? So it's important for a school social worker to have a good understanding of how dyslexia might show up in kids and how to help support families to get the resources that they need. As we learned earlier, you don't have to move ahead quite yet. As we learned earlier in the slide presentation on the myths, that dyslexia is pretty common. And so if you're working in community centers, mental health centers, you need to be prepared to encounter people who have dyslexia, who may have never had the privilege of getting a diagnosis while they were in school. And it is very common in other settings that social workers work to interact with people who have undiagnosed dyslexia. So it's really an important thing for social workers to train and know. I love that we got to learn about the universal screening that's been passed, because that is definitely an area that is going to make a big difference for early identification of kids. And that's an important area of advocacy that social workers can play. Also, when a child is screened and found to have some risk factors for dyslexia and needing to move forward, just like we reviewed the myths at the beginning of this presentation, that's an important role a school social worker can play, both in educating all people within the school setting about those common myths, and also working with parents to understand that, so that they better understand what their child may be facing and how they can work together, and that we can partner together as a team to help support their child. Can move forward now. So that role of family engagement, the first step is building rapport, trying to establish a positive relationship. And sometimes that can be really difficult based on how we are referred to working with the family. So with Thomas's family, there's a lot that I don't yet know about them that I would want to work to really get to know. We've learned that the parents are divorced. I don't know how well those parents get along. And sometimes divorced parents do not co-parent very well. So that will be something that we'll want to get to know. Who is the primary caretaker for Thomas? Who makes these medical and educational decisions for Thomas? What were their experiences in school? We also know that there is a history of learning disability in this family from the beginning of the presentation. Well, that may mean they have had some negative experiences with school in their background. So we may have a lot of work to do in a school setting to try and build that bridge with the family and really build rapport with them. Helping to educate the family so they understand a diagnosis of dyslexia. They may have their own biases about that. They may feel that means their child is stupid, can't learn, etc. And so really trying to help them understand that the child can learn, has lots of opportunities, you know, and we have interventions that can help create a really bright educational future for their child. There's a lot of research out there that indicates that parents are embarrassed by this diagnosis. So that all ties into those myths, etc. Making sure this family has the resources they need. If they're worried about housing stability, about food access, about access to medical care and medication, that they have the resources they need so that they can take care of those really important basics and be able to focus on Thomas's education and his intervention. Really trying to offer the family support. Families might feel really frightened and confused and concerned with a diagnosis like this. You don't know what to do. What are my next steps? So making sure that they have a safe space, and the social worker can be that safe space where they can express their fear and frustration and concerns for the future. Helping to serve as a liaison with the school, those IEP type meetings where there's a counselor and a school psychologist and a teacher and an administrator, you know, all across the table, and you're sitting opposite them, can be very intimidating. So making sure a parent knows what to expect in that meeting, knows how to prepare for that meeting, knows how to ask questions, and feels confident that they're getting the support they need. And really, social workers, an important role that we play no matter where we work is advocacy and working to change policies so that they better serve the people that we work with. So that can be a really key integral role of a social worker who's working with families who have kids with dyslexia. And another exciting thing we can do is help build a support network so that the parents can connect with other families who are experiencing the same thing. They can receive mentorship from other families and be empowered to provide that mentorship to new families with that diagnosis. So those are ways that social workers can engage with Thomas and his family.
Okay, thank you, Dr. Miller. Our last section will be Dr. Andrews again is going to speak more specifically to the intervention process for homeschool children. So I'll leave it to Dr. Andrews.
Thanks. So this applies to both kids who attend online charter schools and also traditional homeschoolers. Certainly online charter schools, kids go through the same IEP process frequently that they would in a brick and mortar school. But sometimes there is the possibility to choose, for example, an offline curriculum instead of an online curriculum. And then of course, with traditional homeschoolers, parents do have personal agency in curriculum choice. So there are a few options for private intensive instruction. Both Linda Mood Bell and Orton Gillingham are very explicit, direct, individualized, multisensory. They both, Orton Gillingham starts with letter sound correspondence. Linda Mood Bell starts with, you know, how your mouth feels when it makes a particular letter sound. And then both of them move up through complex reading. So there are academies and camps that are admittedly quite expensive. Those occur outside of Oklahoma. We do have tutors and speech therapists who are trained to offer those programs in Oklahoma, though. And the nice thing is that Orton Gillingham, both of these are evidence-based programs that have a lot of research behind them. And there are several homeschooling curricula that parents can use at home that incorporate Orton Gillingham methods. So all about reading, Barton reading and spelling, logic of English, and reading horizons are all good examples. And all of those are multisensory, they involve games. It's fairly scripted so that parents can be confident in providing reading instruction to their child at home. So it is definitely possible to provide appropriate services for a kid with dyslexia, even if they're homeschooling.
Thank you so much. Okay, so that concludes our final section, but this is a list of resources that if you're interested in learning more about dyslexia or kind of learning more about the process of seeking out help or evaluation for dyslexia, these are some good resources that we wanted to provide. And with that, we'd like to open up for the question and answer section.
We have our first one in the chat. It's from Krista Bellick asking, what is the relationship between dyslexia and ADHD and how might this impact treatment decisions?
I can take that one. So that's a great question that gets asked quite often. And again, one of those things that pediatricians, neuropsychologists, lots of folks are called upon to try to tease apart. I think like Dr. Shelkoff said, you can have ADHD, you can have dyslexia, or you can have both. When we have a child that comes with perhaps the complaint by parents is they're having trouble reading, it's important that we try to understand all aspects of that. And if they, we would usually use our tools to assess for ADHD. And if they meet full criteria for that, we still want to try to understand if those reading challenges may be related to difficulties beyond attention. Certainly, if you're having struggle focusing, you might have trouble with reading, but we probably want to understand a level deeper. That said, if they have problems with focus and they meet full criteria for ADHD, then we would proceed with treatment. And sometimes aspects related to focus can get a little better with reading, but that's not to say that ADHD medications are going to treat dyslexia. So I think that's a real important point, that we can improve the focus that might be needed and the decreased activity level to sit and participate, but we cannot cure or treat the underlying causes of dyslexia by treating ADHD.
Thank you, Dr. Bax. We also have another question. It's like this one is a two-part asking, is there a role for medication in treating dyslexia? And then additionally, what is the role of vision therapy?
As the pediatric ophthalmologist on the panel, I will approach this in terms of medication specifically for dyslexia. no, there is no role for medication to treat dyslexia. However, if there are any coexisting conditions like ADHD or something like that, then medications can be helpful to treat those conditions. And then that can kind of work similarly to kind of help the child with their focus. But again, that's not going to treat their dyslexia. The key to treating dyslexia is a structured literacy approach, as we've mentioned and kind of gone into with phonemic awareness, and vision therapies, including colored lenses and psychotic training and things like that, are not a helpful treatment modality because the issue is not with the eyes. The issue is with language. And so that is definitely the key to treating dyslexia. And like I said, if there are coexisting conditions, then you may consider treatment for those, but that specific issue of dyslexia is not going to be addressed with that. And I don't know if anybody else on the panel wishes to speak to that, but.
Thank you, Dr. Yanovich. And it looks like our next question is, it is apparent that a multidiscipline approach is important when treating dyslexia. What are some barriers with working across so many disciplines, and how do you think those barriers can be improved?
I love that question. And I feel like events like this are a wonderful first step so that we can learn about what each discipline does, how they approach dyslexia screening and treatment, and how they might engage with Thomas and his family. So I feel like this kind of opportunity to learn from such a broad panel really sets the stage well for helping to remove some of those barriers and create better understanding. It would be really lovely to carry these sorts of trainings forward beyond for students, right? To create this as a continuing education kind of training for all of our different disciplines would also be really helpful.
I think for speech language pathologists working in schools, they're already in an excellent interdisciplinary setting with the different people involved in the educational side of the child's life, at least, all sometimes in the same building. So that definitely creates an easier way to establish those relationships, so that when you have a child who has, and many of the kids that we see have a lot of other people involved in their lives. When we're in clinics and the parent brings them in, we get to see the parent more, but then we don't necessarily get to talk to the teacher, the gym teacher, the person at the lunch who, sees how they do in recess, etc. So I think that it's up to the person providing the services to really seek out, develop those relationships, and really take advantage of the opportunities they have, and just be aware that there's a need for that.
Okay, unless we have any additional questions, I believe that concludes the Q&A. And we did want to point out that it looks like Michelle DeBerry from the State Department of Education has also dropped a couple comments in regard to mandatory training that the state is developing for public school teachers. So that's an exciting addition, and her email is also there if you have any questions for her. And I think I'll give it over to Colton to conclude our session. Thank you.
Okay, with that, I think that our session is concluded. I want to thank everyone on the panel for putting in time to teach us very deeply about dyslexia and from a bunch of different perspectives. I know it was something that I knew very little about prior, and I feel like I've just come leaps and bounds since then. So thank you all very much. And I appreciate everyone for coming out to listen to this. We have posted a post-presentation survey. If you could please fill that out, it really helps with knowing kind of how the presentation went and how well we've kind of addressed our learning objectives. But with that, I guess I will say good evening and enjoy your Cinco de Mayo, and thank you for coming.